ECG basics, posterior ECG leads, ST elevations more than 0.5 mm in leads V7 to V9 is diagnostic of posterior wall MI. So where do we place the V7 lead? That is left posterior axillary line. V8 in the tip at the tip of the left scapula. V9 left paraspinal region. V7 left posterior axillary line in the same horizontal plane as V4 to V6. V8 at the tip of left mid-scapula in the same horizontal plane as V7 to V9. V9 left paraspinal region in the same horizontal plane as V4 to V6. V1 to V3 should remain unchanged from standard 12 lead ECG. Posterior MI is suggested by changes of horizontal ST depression, tall broad R wave more than 30 milliseconds, upright T, dominant R wave. These findings are seen in V1 to V3, R to S ratio more than 1 in V2. V6 is good reference point for the horizontal placement of posterior electrodes. V7 to 9. If you do not have access to a 15 or 18 lead ECG machine, then leave V1 to V3 in their normal position and use V4, V6 as V7 to V9. Here you can see the T wave is upright, there is ST depression. So there are some tips for recording posterior ECG. Arm and leg electrodes remain unchanged. V4 connects to V7, 5 to 8, 6 to 9. Remember, a hand write posterior leads on ECG paper. Relabel V4 to V6 as V7 to V9. Findings may be very subtle, that is only 0.5 mm. Always double check lead placement to confirm the correct anatomical space. Posterior MIs involve the dorsal infraatrial part of the LV. Nearly 20% of MIs. Most will also have inferior or lateral MI simultaneously. Isolated posterior MIs are less common, that is 3 to 11%. Vessels affected include right coronary, left circumflex and its branches, and right circumflex. You only need 0.5 mm ST elevation to confirm posterior MI. That is it for today. Stay tuned for more.